Okay, Dr. David, I understand that there is some kind of updates in the Canadian guidelines. If you
Yes.
just can let us know exactly how the semaglutide is positioned in the new guideline recommendations.
Yes, sorry, my colleague, my expert and excellent colleague, Sue Pedersen, chaired the reformation, the reanalysis of our pharmacotherapy chapter in our Canadian clinical practice guidelines for the treatment of obesity. How we do that is we take Sue Pedersen, and we lock her in a room for 2 months. She's amazing. And with some other great authors, Megha Podar, Priya Manju, they have created a new table that I advise all primary care physicians listening to go look at. It is a table that addresses the newer medications, semaglutide and tirzepatide, relative to 3 categories. Metabolic complications, considering a patient has, for example, prediabetes or coronary vascular disease or MASH, which medication has the highest level of evidence to support use. Mm-hmm. So we can start choosing the medications based on phase 3 data.
Okay.
The other 2 categories are mechanical, think sleep apnea or knee osteoarthritis. And then the other category is patient-reported outcomes. Mm-hmm. And so if I start with the metabolic complications, what stands out most noticeable as to the highest level of evidence between these next generation medications, tirzepatide and semaglutide? One of the standouts in our guidelines you will see is that, and this is because of the now very famous landmark clinical trial called the SELECT trial, we have the highest level of evidence of the ability of semaglutide in those with established heart disease to reduce the relative risk of heart disease outcomes, real MACE outcomes. Mm-hmm. Very quickly to review, some of the listeners may not be aware of the SELECT trial. Mm-hmm. A landmark clinical trial comparing semaglutide 2.4 milligrams to placebo in subjects with established heart disease, either a previous heart attack or hardware in their heart like stents or peripheral vascular disease. And these individuals were followed for up to 4 years, half on semaglutide, half on placebo. And the outcomes, the primary outcomes that are being measured and targeted are real MACE outcomes, a composite of cardiovascular death, what we call body bags, non-fatal heart attacks, and non-fatal strokes.
Okay.
What did we find? We found that at the end of 3.5 years, there was a relative risk reduction in the semaglutide group of 20%, 20% relative risk reduction across all MACE outcomes. This was the first time we have seen patients with obesity without diabetes with a GLP-1 receptor agonist showing real reduction in MACE outcomes. And so if we go across CVD in the chart in our guidelines, you will see the highest level of evidence with semaglutide. Currently, with tirzepatide, there will be a blank spot. Why? Because we simply do not yet have the cardiovascular safety data. There is an equivalent clinical trial with tirzepatide, which is called the SURMOUNT MMO. Individuals without diabetes, living with obesity. It is a both secondary and primary care prevention clinical trial, and we expect the data in the year 2027 or in the year 2028. So in the meantime, semaglutide has that spot for cardiovascular risk reduction. Going along other categories, we see now with MASH, because of the ESSENCE trial, which I mentioned earlier, we see stronger data, and you can see this in the chart with semaglutide. And then finally, I mentioned there was a category called patient-reported outcomes.
PROMS, yes.
PROMS. One of the patient-reported outcomes, it's a really interesting concept, is cravings. And so can I share a very funny story very quickly?
Yeah, sure.
I was in Japan a number of years ago with executives of the manufacturer of semaglutide. And I said, I love liraglutide, but it has no data that it reduces cravings, and cravings are the central symptom of obesity. I said, if semaglutide comes onto the market and you don't have data on cravings, I will quit obesity medicine. And so you see now in the step 5 trial, they just put in, almost awkwardly, something called the control of eating questionnaire. And the control of eating questionnaire is a well-validated measure of what I describe as the main symptom of obesity, appetite dysregulation. And the control of eating questionnaire data in step 5 is quite outstanding. All the elements of the test favor semaglutide, showing significant reductions in cravings. And so that's another reason. We don't have this test yet with tirzepatide. I imagine we will. But again, it's another difference in the chart where we will see semaglutide as favorable for reducing cravings, the main symptom of obesity. And so please reference that chart in the new addendum, new adjunct to the Canadian Clinical Practice Guidelines Pharmacotherapy chapter. That's what I would suggest to all the listeners. You can find it on Obesity Canada, and it's written by very good friends of mine.
Excellent.
Yes.
Thank you.